And anyway, John Frederick knows the Indian way, so that's waiting for
no problem.
No
problem.
Yeah.
Sanjay.
সঞ্জয় কোথায় হোস্ট আছে তাই না?
সঞ্জয় সঞ্জয় শুনতে পাচ্ছো?
John Frederick has a few slides, so he will share the slides when the time comes.
No, I think he has already allowed
Okay.
slide share, so you can try.
Yeah, it seems to be activated. I should be all right.
Yeah,
Okay.
it should be.
In any case, I don't really need them, but I just have a few data slides that people may find interesting. So
So Hachin, how is Kolkata? Is it still very wet? Is it raining very heavily, or?
No, it seems now it's over. Until day before yesterday, we had rain,
Okay.
but now I think it's absolutely clear now. But still, some of the districts are flooding because of this excess water flowing through the river, and so that the DVC actually they release some water, and that that's the usual stuff, and
The lowering.
So that some areas got flooded. So that's the thing.
Okay.
But Kolkata is all right.
Okay. But look at the way that cyclone has traveled all the way to Oman now.
Right. But it's becoming more and more frequent. It's becoming more and more frequent now. I mean, almost every year we see something or other is coming, and this cyclone or.
What they say is that good old days, it is October, November used to be the cyclone season. Now we see already in September we have cyclones.
That's
and
right.
Then April, May, June, anytime it's a cyclone sort of a thing. It's so it's changing. And also West Coast was not getting so many cyclones, but now we are also cyclones now.
Shubhrata, Sanjay must have put it on book live, I suppose. He told me that you put it on IDSK Facebook live. Yeah, he has done it, I think. Because only the host can do it. So I told him to do it. And so he remains the host, right? I mean, so no problem with that, isn't it?
Yes, Sanjay already started sharing the feedback. Facebook live.
So he remains the host, so no problem.
Yeah, he remains the host. Yeah.
Okay, no problem.
Somebody is open, so that's why some kids are talking.
We have to request others to mute their mic.
Please mute your mic.
Yeah, we should be good now.
I think we should, we can start now.
Yeah.
Okay, yes, sir, you can start.
No, please, Shubhrata.
Yeah, so welcome and good afternoon to all. This is our second webinar under IHEPA's webinar series. And you know about today's topic. Today's topic speaker. I'll request I'll now request Professor Narayana, the president of IHEPA, to introduce the speaker of the day and the chair of the session to the virtual audience. Thank you.
Thank you, Subrato. Good afternoon to all and welcome to this webinar. Now, today's speaker, John Frederick Levitt, of course, he is known to some of us and a close friend of ours, but many of you might not have known him. But he is an old India hand because his thesis, correct me, John Frederick, if I'm wrong, is on India. In fact, he worked on urban health, cost of urban healthcare, and issues like that. So his work was very important for us because that was the first time somebody handled urban health the way John Frederick actually handled it. So he's a medical graduate from the University of Montreal. He did his master's and also PhD. And then he worked for a few years in Quebec, actually in the National Institute of Public Health, and did some very, very interesting work over there. Then in 2017, he went over to, Australia. In that sense, he knows Canada, he knows India, he knows Australia. So, if somebody has to speak on COVID, we cannot think of a better person because with that sort of an experience. And he's actually joined the New South Wales Agency for Clinical Innovation as Chief Executive in June 2017. And he was, he's leading the analysis of health system and its improvement. And he's combining his experience because he's a medical graduate. So he has vast clinical experience. He's combining that with his analytical and academic research. And he is an adjunct professor at the Center for Primary Healthcare and Equity at the University of New South Wales. Yeah, so that's John Frederick for you. He's a speaker. So I think it's I am extremely thankful to him that he agreed to speak, in this public health series. Thank you, John Frederick. Now, Professor Achin Chakravarti, who is going to chair the session today, I don't think I have to really introduce him to this audience, but just for the sake of introducing, he, well, how do I introduce you, Achin?
You don't have to.
He has taught in Harvard, Oxford, Paris, and is an excellent teacher. And the very fact that he has taught in these 3-4 places tells you that he's an excellent teacher and in great demand. And then he was my colleague at Center for Development Studies for how many years, Achin? 10 years? Or,
8 years.
8 years. And then joined IDSK and is currently the director of IDSK Kolkata. And he, his forte is welfare economics and health economics. He has also taught in Achutaman Center for Health Science Studies, the MPH students. And I think I'll stop with that. Now I request Professor Achin to conduct the meeting and do it the way you feel like doing it. So thank you very much and welcome to all of you. Thank you.
Thank you, Professor Narayana. Professor Narayana has already introduced the speaker, so I'm not going to take any more time on that. And so let me welcome again Dr. Jean Frederick Levis. He's a very good friend of ours, and we are all waiting for his today's presentation. He's going to present on economics of COVID-19 the public health perspective. Over to Zofredrik. Please, you can start.
Thank you, Achin. Can you hear me well?
Yes, yes.
Excellent, thank you. So thank you, Professor Narayana, Professor Chakraborty, and Mukherjee. It's a real pleasure for me to join you today for this seminar, especially on an auspicious day for India, such as the birthday of Gandhi. Thank you for taking the time to listen to this seminar, despite today being a public holiday. So just before I get to the topic of my presentation, which is really around trying to reflect on public health and the current pandemic and how public health had to deal with balancing the health of the population and the economy of societies. Before I do that, I just want to also acknowledge my very strong ties with India. As Narayana said, I conducted my studies in South India on urban health and access to healthcare, and that led me to write papers that have really shaped my career. So I owe a lot to India on many fronts, in addition to also having worked as a clinician in the Nilgiri region of Tamil Nadu with Adivasi populations. So it's a real honor for me to talk to you today. I do want to say I'm not an economist, and I'm not going to pretend to be an economist. Obviously, through my studies, I have combined public health medical studies with some economic studies. And I hope that you will forgive me for probably sometimes making some mistakes with key concepts of economics. However, I really wanted to give a public health perspective because public health and economics had to work a lot together over this pandemic. And there's certainly a lot to learn in terms of better managing crises like this in the future. And of course, in terms of getting out of COVID as well. In the Australian context, as Narayana mentioned, I'm leading the Innovation Agency in New South Wales, but I'm also currently leading the COVID-19 Critical Intelligence Unit for the state. And in this role, I'm supporting decision-making of governments and I'm leading the scientific evidence and data intelligence activities for the state. So today, I wanted first to reflect on the pandemic first, and then discuss quickly the Australian context with regards to the pandemic. And then I'll take some time to talk about the public health response to the pandemic and some of the challenges that have been faced by public health, especially in terms of balancing the economic and health impacts of the pandemic. And I would like to finish after this by discussing some equity issues. First, from the angle of needing or to express the need for a more micro and localized management of the pandemic in the future. And second, in terms of discussing the need to re-engage democratic processes to find a balance between economy and public health, understanding that in many countries we are experiencing different phases, different stages of the pandemic. Many countries are fortunately seeing their vaccination rates increasing, and that means that we need to reflect on the way we've managed the pandemic from a public health perspective and start to bring societies back to a discourse around what should be the right balance between economy and public health in future months. So just a few reflections on the pandemic to start. As you know, the SARS-CoV-2 pandemic is a worldwide crisis, and it still represents many challenges and a very changing landscape in various countries. Not every countries are at the same stages in terms of the pandemic, and certainly the Australian path has been different than other countries as well. But it's fair enough to say that all countries have been affected. No countries have been immune from the virus. And certainly no countries have been immune from the impacts that public health measures have had on societies as well. This pandemic has been characterized by a context of uncertainty, a context of emerging evidence, but also changing evidence that was appearing in the literature all the time. And traditional public health and modern public health measures really had to be combined and to be evolved together to respond to the pandemic in many different countries. This was very different from other infectious diseases outbreaks. It happened at a very different time than previous pandemics. And that has been reflected in the way public health has responded to these challenges. I wanted to highlight some key aspects of the pandemic before I get into the topic of the discussion today. This pandemic has really been related to the rapid spread of disease due to the highly mobile populations that we have in the world at the moment, but also the very integrated economies. In Australia, we've had outbreaks that were created, for example, by cargo ships coming in the country, bringing goods to Australia with crews amongst those ships that had COVID-19 and at times introduced it in the country. A second aspect has been the rapid communication and social media impact of this pandemic. It really doesn't take very long for everyone around the world to be aware of a new variant emerging, for example. It doesn't take much to be able to assess what's the rate of illnesses in different countries, given all the tools that we have. This pandemic has also been really characterized by very rapid technological developments. The genomic work around the virus was done in a matter of days in terms of identifying the genome of the virus. Very quickly, tests were developed. Therapeutics have been in development as well, and many of them have been used in certain places, even though, unfortunately, we still remain without very good therapeutic options, and certainly not cheap therapeutic options apart from ventilation support for patients. And then, of course, there's been the vaccine development, which has been absolutely amazing in terms of its speed, rapidity, and effectiveness. And really, those technological developments had never been seen before in a context of infectious pandemic like this before. And the fourth aspect I wanted to reflect on this pandemic was also the very integrated nature of the supply chain for many health and medical products. And this has really created a lot of challenges for public health responses in many countries, especially lower economies or emergent economy countries compared to richer and wealthier societies. And even in a very rich country like Australia, this integration of the supply chain has really created massive issues to ensure an appropriate supply of drugs, an appropriate supply of protective equipment, and a lot of pressures, of course, on the budgets of various countries because of the way this has driven prices very high because of competition for obtaining these products. One of the underlying factors that we need to consider as part of this pandemic is also the very high level of economic inequalities around the world that was present between and within countries before the pandemic emerged. And that really has underpinned a lot of the way the pandemic has evolved, as well as driving the impact of the public health responses and the public health measures that had to be put in place to control the pandemic. It is a world of very high inequalities, and the pandemic was was influenced by this in many different ways. And I hope that later in the talk, I can give you some examples about how those inequalities have really affected our response to the pandemic. So, as mentioned, I currently live in Australia, and I've got my professional roles mostly in Australia at the moment. And Australia has gone through a very particular pathway through this pandemic. It has experienced 4 waves of the pandemic, but mostly the first 3 were small clusters until the most recent Delta variant outbreak. So in March and April 2020, like everybody else, we had the start of the epidemic. For us, it was mostly travel related. And as soon as we closed our borders, we were able to, in a matter of weeks, bring back the cases of COVID-19 to 0 in the country. And then in July 2020, just a few weeks later, we had a first outbreak coming out of hotel quarantine and also related to an outbreak coming from our neighboring state of Victoria in the southern part of Australia. And again, because of very harsh public health measures, we were able to bring the cases back to 0. Then we had a third outbreak in December to January 2021, which is not quite clear where it came from, but it's possibly an airplane pilot that brought the virus to a specific area of Sydney, a peninsula in Sydney, which became totally locked down for a few weeks. And then we brought, again, the cases back to 0 in the country, as New Zealand had done many different times as well. And then the last week of June of this year, we saw another incursion, but this time it was the Delta variant, and it created an outbreak that brought our cases up to 1,500 per day at the height of the outbreak. And now we're around half of that, with cases going down at the moment, but with no hopes that we're going to bring them back to 0 again. And therefore, Australia is now at a stage where it has to learn to live with the virus, like many other countries around the world had to learn to live with the virus. Just to give you an idea of our public health response. So up until now, the public health response in Australia has mostly been characterized by first, border closures. So it's very, very difficult to get in and out of Australia at the moment. There's very limited international travel. You have to ask permission to leave. And anyone coming to Australia has to quarantine for 14 days in a supervised hotel secured by police. So that tells you how seriously we took international travel as being one of the main threats to our situation. And you may already expect that this has also affected international trade with Australia in a significant way. The second big characteristics of our public health response has been the very high level of testing that we've done. With New Zealand, we're one of the highest testing countries in the world, even though we didn't have very high number of cases. And that enabled us to really do a lot of contact tracing and then ensuring isolation of cases and their close contacts very rapidly. A lot like many of the states in India have actually also implemented as well. Physical and social distancing orders have been put in place, and there are limits to the number of people that could visit each other in different households, even in between outbreaks when we didn't have any cases. There's been closures of schools at various times, and also people had to work remotely when they could. And there's been closure of many non-essential commercial activities. So you can see already that even though Australia didn't have a lot of direct impacts of COVID-19, it was affected very strongly by the public health measures that were put in place. There were limited curfews imposed, and there were a few stay-at-home orders, and we are currently in a stay-at-home orders. I'm talking to you from home at the moment, where I've been working from over the last 3 months. We're wearing masks in public places and at times outdoors as well. And one of the key things that we've had to do also was to very often to stop elective health activities in the system. And you may expect that this has had also consequences on the health of our population for all of the indirect impacts of COVID-19. We've got a strong monitoring and reporting of data in our context and daily communications in the media. And finally, after many months of delays, because Australia did have issues in accessing vaccination, we now have a very strong vaccination campaign and are reaching high levels of our population being vaccinated, which will create specific issues in terms of equity, and I'll talk about it a bit later again. More recently, we've had to shift our perspective towards a micro strategy, a localized strategy to try to control COVID-19. And that will be one of the main topics I will come by a bit later. So before I get into some of the challenges that public health has faced in playing its role in our context, I'll just say that, you know, public health is a professional domain that by definition, has a role to integrate and arbitrate between various determinants of population health. We need to be the arbiters of the balance between, you know, social contacts, liberties, the economy, threats to health, etc., to support the diagnosis of social and health problems, but also to support the design of local and state public policies to respond to these population health challenges. And it's really the role of public health to try to be the body that brings all of this together. But the pandemic has really created a lot of challenges for public health. And that has really happened around the world in most countries that I've been able to interact with as part of my role. First, this was a very different context compared to previous pandemics, but also compared to the usual infectious diseases control efforts that we usually have to do. You know, in the past, we were used to deal with smaller scale infections where subpopulations only would be affected with known pathogens, very often with limited economic impacts, or at least on the short term. And in situations where regular public health laws were sufficient to deal with the issue. But that was not the case with a pandemic like this. It was a new pathogen. There was a lot of uncertainty. And many of the decisions that had to be made that we knew would have impacts on the health of the population and on liberties were done in a context of very high uncertainty. Worldwide, there were issues in mobilizing all the public health resources that were available to face the challenges of the pandemic. And really, that created very big challenges in terms of managing the public health, because most of the countries were having previous investments in public health that were fit for the previous era, pre-pandemic era. But in a pandemic era, you need many more contact tracers. You need more people that will look at epidemiological trends, more people having the time to reflect with key people from different commercial sectors, you know, in terms of what would be the right balance to achieve to try to control this epidemic in a way that provides the least impacts on society and especially its most vulnerable. One of the key things that have been a challenge as well, and I'm sure that it has been the same in India as well, is that very often the impacts of the public health response on the population was very significant and at times bigger than the actual impact of the pandemic. Especially when public health measures were actually successful at reducing the impact of the pandemic. And that created a paradox where people would start to say that the public health measures were creating more harm than COVID-19. But of course, that was because we were successful at avoiding a lot of the very catastrophic potential situation that would have happened if we hadn't put in place some of those public health orders. But that created a real challenge in terms of communicating appropriately, in terms of engaging local communities, and various sectors of economic activities to make sure that everybody understood that we were still trying to achieve that right balance between economy and public health. Interestingly, some countries like Australia, for example, have actually seen a drop in mortality during many of the months of the pandemic. However, there was a rise in other health problems, such as depression, anxiety, and other mental health problems. But it was interesting to see that public health orders reduced road trauma. They reduced cardiac problems in our context. And when we started to try to calculate if there would be excess mortality, what we found is that mortality had reduced. Of course, that was during the previous phases, and at the moment, we're probably seeing an excess of mortality because of COVID-19. But it just shows the complexity of trying to understand what will be the impact of public health measures like this on the health of the population when there are so many determinants of health mixing together. One of the challenges of this pandemic also is that it has not only affected individuals from an economic perspective, it has also impacted the entire country's economies and big businesses and broad groups within societies. And that has created a very different type of pressures on public health officials to stay the course, to maintain the public health orders, to ensure that we were keeping the pandemic in control, understanding that those big businesses were very keen to reopen society and start to trade again. And that kind of pressure may not have been something that public health groups around the world were very good at dealing with, let's put it this way. Ultimately, all of this has made the role of the chief health officer in many countries the most politicized role over the last 2 years. All of this in a context where misinformation was rife, conspiracy theories were emerging, and there were very personalized abuse through social media that could be inflicted on people with such prominent and politicized roles. And I can tell you from many of my colleagues that this has also been a very difficult challenge for many public health officers. Views have been polarized all through this pandemic. Is it airborne or not? Are masks working or not? There's been so many debates. I mean, even the AstraZeneca versus Pfizer debate has been raging in many different countries. And when you look at things and you look at the evidence, you can see that very often those polarization were artificial and not based on real evidence or science. So public health had to tread very difficult places. And one of the places that public health, of course, had to tread very carefully was this balance between economic and health impacts. You don't close an economy and society, you don't force people to stay at home or schools to stop without understanding that this will have significant impact on societies, on the capability and learning of people, but also on livelihoods. And I have to say that public health bodies have tended to take mostly the health perspective in all of this. It became very difficult to balance the economic imperatives, especially when the outbreaks were getting very high. Ultimately, they had to be the defenders of public health and really apply the precautionary principle in a context of uncertainty, whilst not being the ones in charge of the overall crisis response. So public health, to a great extent, at times, had to accept that there would be consequences, certain consequences on the economic livelihood of people in communities to enable society to go through the uncertainties around the health impact of the pandemic on populations. Models were predicting very, very high levels of cases. Mortality has been high in many different countries, and public health ultimately at times had to be the ones to say, we need to close things down. So one of the challenge with this regard of this pandemic has been that it's been a very paradoxical pandemic. Just to give you a few examples, we know the virus is transmitted through droplets and also droplet nuclei, those little, nuclei that float in the air. And therefore, it doesn't necessarily require a long exposure to transmit the virus. But we also know that mostly the virus is not transmitted by very short exposures. So the fact that we could see certain instances of very, very rapid transmission still didn't mean that every single people were at risk all the time from the virus. Another paradox was the fact that most people have mild illnesses with COVID-19, but the amount of people requiring ventilation support means that the healthcare system would have been overwhelmed, even at relatively low prevalence of the disease. And in many countries, less than 5% of people have had COVID-19 so far, but still, this were putting so much pressures on the healthcare system that we needed to keep those numbers very low. And that really meant that for many people, the consequences of the public health measures could seem out of proportion compared to their risk of catching the disease. But the reality is that we wanted to preserve the capacity of the health system to respond. And that created that paradox of very few people, when you look at the entire population having the disease, but still everyone having to abide to public health measures for the good of everyone. Very difficult to convey those messages across very diverse and vast populations. Also, whilst most of the illnesses are mild for COVID-19, we know that the longer term sequelae of the disease are highly prevalent amongst people that have caught COVID-19. And that also created the need to protect people from the infection, even though the infection may seem mild for people. Another paradox that we are still facing and that will create challenges for us is that even very high levels of vaccination will leave millions of people susceptible to the disease in most countries, because not everybody will want to receive the vaccine or will be able to access the vaccine in a timely way. And therefore, in most countries, public health restrictions of some sort will be required on the longer term, even though people will be vaccinated. And again, that may pose challenges in terms of balancing public health and the economy in general. Another paradox from an economic perspective is that the indirect impacts of the public health measures have been significant and distributed to a much bigger group of people than the actual size of the population that actually got the disease. And I want to reiterate that because that was really something difficult to grasp as a public health specialist. And finally, I want to acknowledge that the people most impacted by lockdowns in terms of the impact on their remaining years of lives, for example, were also those that would benefit the most from it in terms of survival. And that created a very difficult situation where many groups were protected from an illness that of course was very serious and dangerous for them. But the fact that we would protect them from that illness was taking away from them, some of the most important aspects of their lives, and at times, at moments where they may not have a lot of years of life left, many years of life left. And again, that created a paradox of really having to force people in being protected against the illness, at times, unfortunately, almost against their desires. Finally, this has been really challenging for the health system as well, because COVID-19 really forced us to stop a lot of other medical interventions. Most elective procedures were postponed because we needed to keep the ICU beds for COVID patients. People became reluctant to consult doctors and access healthcare. And therefore, we know that there's a lot of foregone care that may actually come back later and put an additional pressure on the system. Mental health issues, as I've mentioned before, have emerged, and mental health problems I've seen, and many health problems I've seen, progression of the disease and patients coming later in their disease process to healthcare. And again, that creates a paradox, because you do want to make those decisions from a public health perspective to save ICU beds for COVID patients, but by doing so, you reduce the care for other people, and you know that this will have consequences as well. And it's a very hard balance to strike. So I wanted to finish this by just talking about equity issues from two perspectives. The first one is, as I said, the need for a micro pandemic management or a more localized pandemic management. And the other one is about engagement of society. So in terms of the micro pandemic management, I want to acknowledge that inequity has had a very important role in this pandemic. First, we know that lower socioeconomic status populations were more vulnerable to the infection. They were working in industries where social proximity was unavoidable. They were working in public-facing roles, very often working in food industries. Those were high-risk workplaces where the virus could be transmitted. And they also have bigger families, and very often have comorbidities that put them at risk of the disease. We also know that they've had more consequences from both the pandemic as well as the public health response. People living in lower socioeconomic areas have had more infections and more mortality from the disease. They've had less access to healthcare, and they were the ones not able to work or study from home as much, and therefore really were affected by loss of employment, loss of education and schooling, and very often that put them in a situation where they couldn't really comply with the public health orders because their livelihood was at stake. And finally, more recently, poorer people also have had lower vaccination rates and more barriers to access vaccines in most countries, including Australia, a very rich countries. And that's the case for our Aboriginal people as well in Australia. And that's something that we're actively working on at the moment to correct. So public health really, given all of this, had to shift from a whole of population approach that was seen at the start of the pandemic to increasingly adopt a micro strategy or a localized strategy. That means we need statewide orders, understanding that statewide orders are imposing restrictions on low-risk people and will also impact unequally the poorest. We need to find a different way to control the outbreaks given the endemic stage of the pandemic. And with increasing prevalence of vaccination or natural immunity emerging, the focus will have to shift also to the unvaccinated and those vaccinated that will be most affected and will drive the spread of infection. So what could a micro strategy look like? Well, it's about developing a good monitoring system to better understand the local outbreaks, but also the social drivers of these outbreaks. What are the characteristics of specific communities that make them more vulnerable to the pandemic? We need to engage with local communities to reach the harder to reach, because all through the pandemic, they were the ones that were in no situation to be able to respect the public health orders. And we need to really engage with them and find a way to support them to be able to comply. We need to target the protective efforts towards the most vulnerable. And that really means to prioritize vaccination efforts towards those most vulnerable people. And I am very proud to say that in New South Wales, we've been able to achieve higher targets of immunization in some of the poorest communities once we started to adopt that micro strategy and really starting to understand that the reality is that they were the ones really truly living the pandemic outbreak. We need to provide social assistance so that we can make it possible for these communities to comply with public health orders. And that may mean food assistance if they have to isolate. It may mean to protect them not to lose their employment if they test positive and have to isolate as well. It may mean to provide them with financial support at time. And we need also to communicate in a more targeted way. Just to finish this talk, I wanted to highlight how to address the equity issues of the pandemic and ensure that we can better combine, economic activity with control of the pandemic. We need to re-engage with democratic processes around the world. The pandemic has really created significant challenges. Because public health measures had to be imposed on societies given the scale of the crisis. But that really meant also that it had been more difficult to engage people in the public discourse. And discussing rigorously the balance to achieve between public health measures and economic objectives is something that's going to be very important going forward. There is ongoing discrepancies between who benefits from a health perspective and who suffers from an economic perspective. And we need to recognize that because the impact of measures is not evenly distributed. There's also a discrepancy that we need to acknowledge in terms of who are the big economic losers from the restrictions. Pharmaceutical companies and protection equipment companies have won, of course, because they've got a big market now. Food and entertainment industries have lost. These are the parts of many societies that have been affected. Information technology has boomed, and travel and tourism and more social aspects of economic activity have really gone down because of the pandemic. And we need to understand those power dynamics because the reality is that at times we need to put a public health order to reduce activity in an area that's already affected by the economic downturn. And if we don't understand this impact, then we put those specific communities or part of the economy at a double disadvantage. There is not always a perfect correlation with regards to the economic benefits and the health risks. And it really puts public health in a situation to have to dictate at times which industries would reopen in terms of really trying to optimize the best economy to health ratio, if I may say. And that's not a usual role for public health. And we need to work with experts in economy increasingly and commerce to be able to do that. So I'll just finish this talk by saying that the pandemic, for me, has really created an urgency to really, to a great extent, requiring us to upholding again or setting up again many of the usual social democratic processes that were in place before. We need to transition out of the emergency to get to an endemic stage where the virus is circulating, but in a controlled way. And we need to understand that this process of coming out of the crisis mode towards more of a normal endemic stage of the pandemic has never been subjected to true democratic discussions or votes in most places. It has become a technocratic decision, very often led by public health experts like myself and others, more than a democratic decision. And that was necessary sorry, during the height of the pandemic, but now it's probably time to try to rebalance this and give people a voice so that we strike the right balance. So these are the thoughts I wanted to share with you today. I'll be very happy to take questions and, of course, reactions from my fellow panelists as well. Thank you.
Achin, unmute yourself. Achin, unmute.
Yeah, sorry. Thank you very much, Professor Levis, and it was a very nice overview of how Australia managed COVID, and in the process, hard balance had to be maintained between controlling COVID and the economic consequences of that. And you have rightly said that Australia, I mean, in terms of the measures, I think Australia is one of the harshest measures that in Australia. And it has been also regarded as one of the successful countries in controlling COVID. So on the one hand, we have this success in controlling COVID, but as we are saying that on the other, we have certain consequences which are uncomfortable. Did you have some slides to show some data or something? You said no. You don't want to show them.
No, that's okay. I mean, if there are specific questions, I can always show them. No problem.
Yeah. So no, without numbers, actually, we are fine with that. But I was curious about this, impact in terms of, because Australia is a multicultural country, and you have different population groups of different, maybe cultural background. I think almost like 1/4 of Australians are born outside Australia, right?
Absolutely.
So there are different groups, and I'm sure that different groups were affected differently. So that's one. And second is that the issue of local versus Commonwealth government. And Commonwealth government, and you have this local administration and local government. Even in terms of the differences, like New South Wales, for instance, it's a most populous region, New South Wales. On the other hand, you have places like Tasmania, for instance. So, in terms of the impact, must be very different, isn't it? So would you elaborate on that? Yeah.
Yeah. There's absolutely been a lot of differences across different regions and states in Australia. One of the things that has happened is that we have had closures of borders between states in Australia as well at many different stages of the pandemic. So, for example, at the moment, it's not possible to go out of New South Wales. And we've got a lot of workers working across borders usually that at the moment cannot do that. And, that just shows how public health, again, can have a very strong and rapid impact on economies just by restricting movements of people. There are many regions of Australia that have had still almost no COVID-19 all throughout this pandemic, but it's really at the cost of having isolated themselves entirely from the rest of the country and the rest of the world. So Western Australia, the Northern Territory, Tasmania have had very, very little outbreaks. Of course, New South Wales and Victoria have had more because they've got bigger populations, and most of the people coming back to Australia from other countries were actually arriving in Sydney or in Melbourne. So that has created those. But one of the things that's clear is that it is within New South Wales and Victoria where the pressure to restart the economy has been the strongest, where the people have challenged the most the public health measures very quickly, and where we had to demonstrate that the reality is that we were supporting the economy by controlling the pandemic. And it was not a choice between the two overall, even though, because the economic impact is not evenly distributed, of course, some people were impacted very significantly, and we needed to recognize that. But we needed to, and we didn't know at the start what would be the impact, to be honest. But when the analysis came out and we realized that our economy was actually in a better shape than in many other places, then we started to realize that we could actually align public health measures with economic activity and try to gauge in the right way, reducing the risk of COVID and maintain some economic activities as well. It has required recently also to really identify what are the types of workers, especially casual workers, people working with very unstable employment, and try to understand what were their needs if we were to both protect them and control the illness, as well as help them to maintain a livelihood. And again, that's why I'm really advocating for that very strong micro strategy, so that we don't just have blanket public health orders trying to control the pandemic, but really a true localized work with communities to try to achieve this.
Thank you. So let's have questions from others. There is a question in the chat box from Gareth Wall. Can you read that? Yeah, please.
Yes, I can. Yes, I can. So Gareth is asking if I could expand a bit on the democratic deficit in emergency public health. Yes. So, I mean, to be honest, it was necessary, Gareth, in every country, because the measures that we had to put in place were really extraordinary, you know, impacting on the individual rights in a very significant way. And the reality is that, you know, it's because not everybody would comply with voluntary recommendations to, you know, stay at home or avoid close contact with people, etc. So in our context, what it meant is that basically the law was shifted to the emergency state, and most of the orders now were based on state public health orders announced by the health minister. And the health minister suddenly has got a lot more power compared to what would usually happen, especially in a context where those public health orders were not debated anywhere. You know, there was no discourse of those public health orders in Parliament. Of course, the media is a place where opposition parties can discuss some of those things, but ultimately it becomes very difficult to really truly have a discussion around those. And that's why around the world, there's a lot of inquiries now emerging, because you don't use such powerful measures that are putting usual democratic processes, you know, without having to use them with judgment as well. And certainly in Australia, like in other places, there will be inquiries that will assess if people went too far, you know. So that's going to be something very fascinating to see. It did require, from a public health perspective, to always truly document the reasons why we were imposing those measures, so that we could say, you know, which ones were evidence-based and which one were made in a very, very uncertain context. And having led the critical intelligence unit, I can tell you that I've given advice to decision makers that 4 weeks later I had to change, because the evidence was emerging and changing all the time. So it's very unprecedented. And I think that also from a perspective of managing future emergencies in a more democratic way, we'll need to do evaluations and try to learn from that experience.
Thanks, Jean-Frédéric. Just to come back on that very last point you just said, did the ministers then change the on that changing evidence?
Very often, yes. Not always, of course, because you know, political decisions are political decisions. It's about maintaining cohesions in society as well as responding to health. But I can tell you that the health advice was very, very difficult to counteract.
But John Frederick, you know, it raises a very important point here. Now you have a chief public health officer, and you have your, you know, intelligence unit, and you have the health ministry. Whose word is the final when it comes to some measure? What role does a chief public health officer play?
Yeah, so that's interesting. Yeah. It's a very interesting question, Narayana, because in many countries, it's even more complicated than that, because you also have the chief of police, very often managing the statewide emergency processes. Because if things get to a level of a crisis and there's civil unrest, for example, and that could have happened, and it has happened in many different places, obviously, the police and at times the army have got a very important role. So in our context, officially, the leader of the statewide emergency is the chief of police. And all of the orders that come from public health are made by the chief health officer and signed by the health minister. It really puts an interesting situation because the usual leaders of a healthcare system tends to be the head of the department, or the secretary of the health system, the premier, or the prime minister. Emergencies created parallel systems where operational people in charge of operational responses get a lot more power. And that creates a very different type of political debate and democratic debate. And again, transitioning out of that is not something necessarily easy. And it's something that many societies will have to go through now. And let's see how elected governments will manage, endemic COVID after almost 2 years of having a parallel system, managing it from a public health perspective.
I can see a hand somewhere, Rivu Boshu. Dr. Rivu, do you want to ask a question? You have raised hand? Yes.
Yes, sir.
I think
yes.
No, please. I just wanted to continue that because that
okay. Yeah, please. Yeah.
Son Frederick, the reason why I raised that issue of the chief public health officer is that, see, India, none of the states have something like that. There is no chief public health officer. And health ministry is normally used to health care, not too much of public health. And you have a group of people at Delhi who periodically come out and say something. But the state level and even within the state, district level, situations are very different. So you ended up having very funny situations. So even within Kerala, one district chief says something, and the neighboring district, the chief saying something quite different, putting people at a great sort of a strain. How do you react to this? Because you have worked in Canada and you have the Canadian experience where there is a chief public health officer, and you now say that, that is the last word. Now, how do you respond to this? Because this, I think, is very important.
I sincerely hope that there's going to be at the international level investments in public health systems, because of course in times of pandemic and emergencies like this, their roles have been absolutely fundamental. But the reality is that to progress population health and the health of societies, it's very important to have strong population health leaders as well as strong healthcare system leaders. And we know that the reality is that health promotion and the work on social determinants of health is more powerful than healthcare in determining the health of population on many fronts. Of course, for chronic disease management and a lot of surgical problems and trauma, healthcare is absolutely fundamental. But public health is also extremely important, and making sure that we've got a strong public health infrastructure in most countries around the world really will need to be, an area of increased focus for WHO and other organizations. And I know that it's been years of efforts. I don't want to convey the idea that there's no public health capacity, and in all countries have public health capacity. But I think what you're saying is that this capacity doesn't necessarily get down to a level where actually public health action can be taken. Because public health response to a pandemic cannot just be dictated from the national level. It really needs to be rooted into communities and be rooted at the local level where specific aspects of society, cultures, and the outbreaks need to be managed.
Thank you.
Next, so Rivu, go ahead, and then in the chat box, James has a question. James, Rivu.
Okay. Thank you, sir, for the excellent lecture and the experience in Australia. So, we have been working in the ground levels in India and West Bengal regarding COVID control. and we found that there are two very fundamental things which were very difficult to be implemented. Firstly, about the wearing mask, hand washing, and social distancing. Though they are in pen and paper, they're extremely difficult to be implemented, and like we cannot have so many polices. Okay, so what are the steps you have taken in Australia as a best practice measure for implementing these steps? That is number one question. And number two question is that in the initial stages of the pandemic, a lot of stress was given on contact tracing and contact quarantine. Again, when the pandemic flared up, we found that that was a very wrong approach, because we cannot trace all the contacts and quarantine all of them together. So what is your take on this? So these are my two questions. Thank you.
Thank you, Rivu. Very good questions. In terms of the behavioral factors that you talked about for mask wearing, for example, or hand washing, and I think to a great extent, this extends also to physical distancing, for example. One of the things that we did, because we did face some resistance as well, one of the things that we did to reach out to specific communities was really to engage their leaders, making sure that there would be a lot of discussions amongst religious groups, amongst different cultural groups. We had lots of discussions with businesses and industries so that they would become the advocate of mask wearing and appropriate physical distancing, because ultimately they didn't want their religious center or their businesses to be closed down because of an outbreak. Okay, so a grassroots approach is certainly one area where I would say we've been very strong. And the second thing that we did and worked in our context, but may not work in every context, was to be very clear about the fact that it was not, a unique set of measures that would protect someone from being infected or from infecting others, but really a combination of different things. And of course, mask wearing and hand washing and physical distancing, all those things work together to reduce the infection. We have not policed a lot in Australia. There's been some cases where people were obviously, just blatantly trying to protest, where fines were emitted and things like that. But very quickly there was also a social movement to, if you don't do it for yourself, do it for others. And we all knew that it was cumbersome to wear a mask, but basically we worked on those different approaches with very strong campaigns on social media as well to promote those practices. Has it been entirely successful? Absolutely not, but we've reached a fairly high level of compliance. In terms of the test, trace, isolate, and quarantine, you are entirely right. At different stages of the outbreak, those measures will be more effective compared to at later stages of the outbreak. So we had a fantastic test, trace, isolate system in Australia. I can tell you that, we are still doing, for example, 100,000 tests a day in New South Wales, and we're capturing 800 cases with it. We never went above 1.5% of positive test rate in Australia. And that's because we had a very high level of testing. And then we interviewed everyone at the start of the pandemic. But then very quickly, when we finally got to a significant outbreak, we had to stratify and risk stratify who would we interview, because the reality is that we couldn't keep pace, just like what you've said in your context. There were just too many people to interview. Everyone was potentially connected now, and it was very difficult then to do an appropriate epidemiological investigation. And what we did then is that we focused on high-risk transmission places, and it became a place-based approach more than an individual-based approach. And also we started to rely more on text messaging, using people's phones as much as we could, so that they would isolate as quickly as possible, because ultimately that's what matters, much more than knowing all of the contacts. So at different stages, you have to adapt your strategy. Many countries have been overwhelmed. I've had a lot of contacts with Canada. In Canada, in many provinces, at some stages, they just couldn't keep with the volume. And then they had to shift to a much more high-risk approach, again, trying to reduce the outbreak, understanding that we would not be able to prevent any contacts from being informed and isolated in time necessarily. So that's the advice I have to give. I'm pretty convinced you probably have done that already. I understand you've got a public health background, but no countries have been able to maintain a high level of test, trace, isolate, and quarantine all throughout the pandemic. But one thing is clear: as soon as cases go down, that's when you need to get back on top of it. And when cases start to go back up, need to be on top of it. You may not succeed at completely controlling it, but it's not because you're overwhelmed at the peak of a cluster or an outbreak that we need to disinvest in that approach, because it's still a very, very effective approach at the early or late stages of an outbreak.
Thank you. There are a couple of questions in the chat box. Please go ahead.
Yes, I can see one around wrong medicines. Yeah, so that's been ongoing everywhere around the world. There's been a lot of use of social media to promote medicines that do not work against COVID, and of course at times are very dangerous medicines as well. We faced similar issues in Australia. My unit was, of course, responsible for publishing the evidence around those, providing a lot of briefings to policymakers so that they would send the right message in the public arena as well. But, even politicians have advocated for ivermectin, for example, in the Australian context. So you can't entirely control all of that debate. What's really important is to go back to the evidence and make sure that you have, public-facing products and reports that illustrate and demonstrate that evidence. Because the reality is that very often those things start by word of mouth, but they also get destroyed by word of mouth. When many people start to say, "Oh no, this is not true," there's no value in this treatment, etc., it's much more difficult for people to continue to convey it. So it's not just public health officials and governments that need to convey that message. You really need to, again, try to relay that information so that it becomes a peer-to-peer communication perspective. On the Chief Public Health Officer discussion, sounds like a great expose of strengths and weaknesses of devolution, be it general or sub-state, as well as national or supranational. Yeah, Gareth, it's, every country is different. I've lived in two countries where there's a federal system with a national government and a statewide government, and of course, having worked in India as well, India's got its national and state divide as well. It doesn't always play out in the same way. It all depends how the healthcare and various other sectors of society are split between those level of decision making. So, for example, in Canada, the entire healthcare systems are run by the provinces, and the national government basically just manages borders, approval of new drugs, things that would impact everyone. But really, everything happens at the province level. In Australia, it's more complicated because all of the hospitals are managed by the states, but the Commonwealth manages primary care. And therefore, we had a vaccination program, for example, where both levels of government had a role to play, and that has posed challenges at times. And also, in terms of public health response, there were things that were split and shared. So aged care, for example, is a Commonwealth responsibility, but the reality is that the outbreak was managed by the state. So how do you coordinate the response that needed to be done to protect older people from the pandemic, that was very challenging. And I'm sure that again in India it would have played out in a very different way. So devolution is never homogeneous in terms of what is devolved across different sectors. And a pandemic creates that very complex situation where some things are clearly the responsibility of the local level, but now they need to work alongside other sectors of social activities that are led at the central level. And that makes it very difficult to get a integrated and coordinated pandemic response. And that's where you need also very strong chief health officers at the state level so that they can start to work together and find a way forward. If you don't have that, very difficult to have a coherent nationwide approach. There's a question around...
Question from James about this comparative perspective. Yeah.
Sorry, I'm not sure I see it, Achin. Oh, yeah, okay, yeah.
Yeah, from James, yeah.
Comparative perspective between any two countries. Yes. Yeah, okay, so it's a good question, James. And of course, being in a situation where we were in, we tried to compare ourselves with many different countries, especially Canada, the UK, the US, and for Australia also New Zealand and Singapore were important comparators. And it's very difficult to do these comparative analysis because the reality is that countries experience different waves at different times and at different stages of their economic activity as well. Some countries were booming when the pandemic emerged. Australia was one of them. Australia was in an extremely strong economic position at the start of the pandemic, and certainly it has helped us to go through it. Canada was in a different situation, and of course in the US we can see the heterogeneity of the way they managed the pandemic and the impact that it has had on various aspects of economic society. But one thing I can tell you is that our comparative analysis overall has said that countries that went the hardest to try to control the pandemic are the ones on the medium term that fared the better from an economic perspective. Of course, at some point, this has got a limit because some of the measures that we've put in place in Australia, for example, on the long term, really isolated us from international markets. And this has started to show in our economic activity. And we've had a lot of loss of employment in the last few months. And the reality is that we were at a stage where we knew we had to reintegrate the international market to be able to resolve some of the issues that we were facing. Of course, the best would be if everybody would have a stronger approach towards managing the pandemic. And one of the things that we're really looking at very carefully at the moment is how different societies are reopening their society at different rates of immunization. Canada is a great experience at the moment. Every province is doing things slightly differently. Alberta reopened everything, almost telling people, you don't need to wear a mask. You can visit anyone. There's no problem. And their ICUs were overwhelmed 4 weeks after, even at 75% vaccination. Other countries like the UK, and Garrett, I'm sure you can reflect on that, are seeing a resurgence, but in a way that doesn't overwhelm the healthcare systems at the moment. So even at the healthcare system level, there are heterogeneity and differences that create those comparisons difficult. But one thing is important is that we really need to learn from each other. One of the things that we've done in Australia is that we've established an international expert advisory group that includes expert public health officials from Canada, the US, the UK, Sweden, New Zealand, various Australian states, and we regularly meet to compare our measures and try to find out what is the best mix of public health measures to find a way forward. And that learning from an international perspective is absolutely fundamental. I'm just trying to read another question, Achin.
Go ahead. Yeah. There's a question on Aboriginals.
Yes,
yeah.
yes. So we have been very active at trying to protect our Aboriginal communities. Well, to be honest with you, they were leading that action, that activity. Like in Canada, you know, we do have many remote communities, Aboriginal communities that would be at very, very high risk of consequences from COVID-19. And unfortunately, at the moment, we do have some Aboriginal communities with significant outbreaks. We have worked a lot at devising culture appropriate ways to engage with them. And that really means engaging with community leaders. It means designing educational and communication material that is developed by them, using their own ways to reflect on things. And it also means that we need to make sure that the healthcare system provides a response to their needs, which is in accordance to how they want to be treated. One of the issues for our Aboriginal communities is that they don't want to leave their countries. They don't want to leave their lands. And that means that we need to take care to them instead of taking them to healthcare, for example. And that's something that in Australia we've been very, very strongly committed to. And we do the same with the vaccination program that we have in place. And we do hope that we'll reach high level of protection of our Aboriginal communities in the next 4 weeks. But it's been really an area of focus for us. But one of the things that has been a challenge for us is the distance. You know, we're talking about Australia is a very, very big place. And those communities are very far apart. And getting a good understanding of what was happening in communities and being proactive at protecting infections from coming in at times have been very difficult as well. So engaging local groups is really the only way forward. Yes, Garrett, you expressed something about the fact that the vaccination has changed everything in the UK. It has changed everything in Canada as well. In a similar way, it really changes the public health measures. But my feeling is that this will probably be revised in the coming weeks. I can see the numbers going up. There are pockets of vulnerability in the UK where you probably have to resort back to some public health measures. And it may actually be that you get to more localized public health management. And I do hope that you have that capacity in the UK to be able to do it, especially in urban areas where, you know, that there are very, very diverse communities in those urban centers. You know, test, trace, isolate may actually have to come back in some of them to protect the unvaccinated as well.
Now, if I may intervene, Gareth,
yes, please.
And John, you see what Kerala is doing right now. We have removed most of the restrictions, even when there's a fairly high level of infection. Because as you all know, about 60% of all infections in India, cases in India, are contributed by Kerala even now. But what we do is, we have the local government ward level, there are restrictions. Wards which report fairly high, what's called weekly infection population ratios, they are under very strict lockdowns. rest of the areas, there are not too many restrictions. Now, this keeps changing every week, depending upon what is the WIPR, that is weekly infection population ratio. So that is the sort of a very micro level sort of a control measures that, that has been brought in. But even that has not really helped much, because we have been having this, despite 90% first dose vaccination, we have fairly high levels of, number of cases, and that is not coming down as expected.
Yeah. So, Narayana, 90% vaccination in Kerala, that means that 3 million people never received the vaccine, or 3.4 million people never received the vaccine. And we also know that there are breakthrough infections with the vaccination, probably at the level of 10%. So you're adding another big number, another 3.4 million people potentially. And that really means that the reality is that it's very difficult to live without a certain level of population health restrictions at the moment in most countries. Our public health messaging in Australia at the moment, even after 3 months of hard lockdown, is that when we reach 70% second dose, which will probably happen in 10 days, it's just going to be a new liberties, but not full freedom. And when we reach 80%, there's still going to be some restrictions, and then we're going to see where we land. So, and I think that Canada is going in that direction as well. Ontario and Quebec are reintroducing some measures. They're not harsh measures, because obviously the vaccination does help, and we do need society to go back, go back to work, go back to school. But the reality that we can go back to a totally unrestricted kind of living in the next 2 years is probably not quite correct, and many countries will have to readjust, because again, with at times a prevalence of 1%, many countries were overwhelmed in terms of their capacity to care for those people, and that's one of the paradox. One, you don't need a lot of cases in your community to put at risk a lot of people that require healthcare. And unfortunately, that's the minimum, limiting factor that we need to consider. But it's difficult for elected officials, for example, to understand that, even at in New South Wales at the moment, we've got 800 cases of COVID-19 a day, okay? It's not a very high rate. It's lower than currently what's happening in the UK. It's lower than Canada, much lower than US and Israel. But it's forcing us to use half of our ICU beds for COVID-19 patients. So how can we run a healthcare system with that level of endemic COVID? It's not possible. So we need to take it down so that we can start to treat people that need other kind of care. And that's where, there's a balance to reach that many countries will, have to gauge what's the right balance for them as well. The vaccination program, there's a question from Sayak. Yeah, well, the vaccines are extremely effective. There's no question there. We are estimating that a person that has received a full course of vaccination is 80 times, 80 times less likely to be admitted to an intensive care unit compared to a non-vaccinated person. 25 times less chance of being admitted to hospital compared to an unvaccinated person. And I'm talking about people that catch COVID, So the vaccine protects against infection. It really protects against severe disease, hospitalization, and ICU admissions, and all of the vaccines. As far as I'm concerned, there's very little differences between the effectiveness of the various vaccines. They have similar safety profiles as well, and some varying duration of immunity. But there's still more evidence to emerge about that, the true impact of waning immunity on the capacity to fight COVID-19. I've not talked about that, but one of the big equity issue that you've addressed in previous webinars is, of course, access to the vaccine and boosters. And many countries are actually going down the route of offering boosters more generally to their population already. Fortunately, most countries do so for people that they judge will not have mounted an appropriate immunity, such as older people and people that are immunocompromised. But unfortunately, in some countries, it's much more widely open. And that's something that I have a lot of difficulty with, I have to say. I think it's really important that as many countries emerge to an endemic stage, we need to start to think about the global public health as well as the local public health. And I've not touched on this today, but that's certainly something that we'll need very strong leadership from various countries to make this happen.
Thank you, Jean-Frédéric. So we have almost reached the end of our program today. It was really a wonderful session, and I must thank and we are ever so grateful to you for having given a wonderful presentation today, and also the discussions, the questions, and your responses to the questions. So I'm sure that it enriched all of us, and extremely insightful and analytical, and we learned a lot. Thank you very much. Thank you, and I thank all the audience, all the members of the audience, and for your kind interventions, asking questions, and thank you very much. So, what is now, Subrata?
Yeah, we can close now formally.
Okay.
I just want to thank you all, and thank you for the opportunity to reconnect with my Indian friends and colleagues. It's always a real pleasure, and I do hope that I can meet with you again very soon. So let's get this pandemic under control.
Yes, thank you. Thank you, Jean-Frédéric.
Thank you.
Take care,
Bye.
everyone. Take care.
Thank you. Take care.
It has been wonderful. It has been wonderful. We'll keep in touch.
Thank you.
Thank you.
Thanks.
Thank you. Bye. I think the meeting is closed. Yeah. Thank you.